Determination of the apical terminus and cleaning the apical patency. The second controversy to be discussed surrounds the determination of an accurate working length, one of the most critical steps of endodontic therapy. The cleaning, shaping, and obturation of the root canal system cannot be accomplished accurately unless the working length is determined precisely. And if the working length is to be established slightly short of the apical foramen, what of that tiny space that lies beyond the constriction, the apical patency area? What if this space contains toxic debris and harmful bacteria that could prevent future healing and repair? What if this space contains toxic debris and harmful bacteria that could prevent future healing and repair? Simon has stressed the need for clarification and the consistency in the use of the. Simon has stressed the need for clarification, not classification. Simon has stressed the need for clarification and consistency in the use of terms relating to the working length determination. Working length, you can see in the figure 29, is defined in the endodontic glossary as the distance from the coronal reference point to the point at which canal preparation and obturation should terminate. Means what figure 29 is showing, care should be exercised to establish the position of the foramen. Hopefully it appears at the apex A. Hopefully it appears at the apex A, and zero point 0.5 and 1 mm is simply subtracted from the tooth length as a safety factor. See the lateral exit of the canal B. Canal B is sometimes seen in the radiograph or discovered by instrument placement and re-examined radiographically. Today, electronic apex locators are important instruments for determining the apical exit of root canals. The anatomic apex is the tip or end. The anatomic apex is the tip or the end of the root determined morphologically. It is determined morphologically, whereas the radiographic apex is the tip or the end of the root determined radiographically. Simple. Anatomic apex means is the tip or end of the root determined morphologically, whereas radiographic apex is the tip or end of the root determined radiographically. Root morphology and radiographic distortion may cause the location of the radiographic apex to vary from the anatomic apex. The apical foramen is the main apical opening. The apical foramen is the main apical opening, that is, entrance or exit of the root canal. It is frequently eccentrically located well away from the anatomic or the radiographic apex. Apical foramen is frequently eccentrically located well away from the anatomic or radiographic apex. You can see in the figure 30. You can see the figure 30 in which the apical foramen, which is some distance from the radiographic apex, stresses the importance of finding the actual orifice by electric apex locator EAL. D. Here the D indicates dentin, C indicates cementum, right? Here D indicates dentin and C indicates cementum. You can see the apical foramen. Palmer investigation showed that this deviation occurred in 68 to 80% of the teeth in his study. An accessory foramen is an orifice on the surface of the root communicating with a lateral or an accessory canal. They may exist as a single foramen or as multiple foramina. This is the meaning for accessory foramen is an orifice on the surface of the root communicating with a lateral or an accessory canal. They may exist as a single foramen or as multiple foramina. Now let's talk about the apical constriction or minor apical diameter. Apical constriction or minor apical diameter is the apical portion of the root canal having the narrowest diameter. This position vary this position may vary but is usually 0.5 to 1 mm short of the center of the apical foramen. This position, what position? The position of apical constriction may vary but is usually 0.5 to 1 mm short of the center of the apical foramen. The minor diameter widens apically. The minor diameter widens apically toward the foramen, that is major diameter. The minor diameter widens apically toward the foramen, that is major diameter, and assumes a funnel shape. This is the area of apical patency. This is the area of apical patency or apical patency area that will be discussed later. This is demonstrated in figure 31. This is the figure 31, the diagrammatic view of the root apex. The importance of differentiating between the minor diameter, that is apical constriction B, and you can see the apical constriction is shown by the letter B, C, and the major diameter, that is radiographic apex, that is the is shown by the A in the diagram is apparent. The apical third is the most studied region of the root canal. Dummer and his associates reported many variations in the apical constriction. Usually the apical constriction is the narrowest diameter of the apical third of the root canal. It is usually lies 0.5 to 1 mm short of the actual foramen. In 6% of cases, the constriction may be blocked by the cementum. In 6% of the cases, the constriction may be blocked by the cementum. The cementodentinal junction is the region where the dentin and cementum are united. The point at which cemental surface terminates at or near the apex of the tooth. It must be pointed out, however, that the cemento-dentinal junction is a histological landmark that cannot be located clinically or radiographically. Note: it must be pointed out that the cemento-dentinal junction is a histological landmark that cannot be located clinically or radiographically. Langeland has reported that the cemento-dentinal junction does not always coincides with the apical constriction. One more point: cemento-dentinal junction does not always coincide with the apical constriction, and the location of the cemento-dentinal junction also ranges from 0.5 to 3 mm short of the apical constriction. See, the location of the cemento-dentinal junction also ranges from 0.5 to 3 mm short of the apical constriction. Therefore, it is generally accepted that the apical constriction is most frequently located 0.5 to 1 mm short of apical foramen. Therefore, it is generally accepted that the apical constriction is most frequently located 0.5 to 1 mm short of the apical foramen, but with variations. These variations may be revealed by the patient's reaction to an overextended instrument or by an electronic apex locator (EAL). These variations may be revealed by the patient's reaction to an overextended instrument or by an electronic apex locator. Now to complicate matters further, Brinolf, you can see in the figure 32, has pointed out that the apical constriction that may disappear completely when apical disease destroys by resorption the entire apical structure. That the apical constriction may disappear completely when apical disease destroys by resorption the entire apical structure. You can see in the figure 32 Brinolf's interpretation of the normal and resorbed lamina dura. You can see in the left there is a normal and resorbed lamina dura, the left side. The radiographic appearance of the normal lamina dura under magnification in the center, right? Now, loss of lamina dura at the apex along with inflammatory resorption as a result of necrotic tissue in the canal. In the picture C, you can see there is a loss of lamina dura around the apex due to inflammatory resorption. You can see Here A indicates for soft tissue. A indicates soft tissue. B indicates bony trabeculae or bone trabeculae. C indicates root canal, and F indicates foramen, and L indicates PDL, M indicates medullary space, and right. This is the necropsy of the specimen, detailed in center. Wien, you can see his recommendations in figure 99. In figure 33. Wien faced this complication early on and recommended a compromise based on the radiographic evidence. Wien faced this complication early on and recommended a compromise based on the radiographic evidence. If in the radiograph there appears to be a normal periodontal ligament width, if in the radiograph there appears to be a normal periodontal ligament width, that is, no bone or tooth resorption is evident, the working length should terminate 1 mm, that is safety allowance, or safety factor from the apical foramen. If there appears to be bony resorption but no apparent tooth resorption, the working length should be shortened by 1.5 mm. On the other hand, if both bone and tooth resorption is apparent radiographically, the length of the tooth measurement should be shortened by 2 mm. The length of the tooth measurement should be shortened by 2 mm. This should draw back the point of apical constriction far enough in the canal to establish an apical stop. This should draw back the point of apical constriction far enough in the canal to establish an apical stop. This should draw back to the apical. On the other hand, if the both bone and tooth resorption is apparent radiographically, the length of the tooth measurement should be shortened by 2 mm. This should draw back the point of apical constriction far enough in the canal to establish an apical stop. Enlarging instruments and obturation should not proceed beyond this point. In 1922, Davis was the first to suggest that careful treatment of the apical tissue was a requirement for success in root canal treatment. Careful treatment of the apical tissue was a requirement for success in root canal treatment. Wien's recommendation